So welcome everybody. Thank you for taking this time on a late afternoon, probably with real summer temperatures throughout, because we want to share a very important topic with you, and this is all about encouragement. So Martin will be so nice and share the slides. Okay, and here we are. So I want to guide you a little bit through where we currently stand with the European Standard Clinical Practice Guidelines, and in particularly with the registry. I will be very brief on the backgrounds, because you know them very well, and we are actually very excited that they seem to be very well perceived. And Adriana has done a very nice overview on all your activities, which is very nice to be shared, which will be do. So in our background, you know, this was a very intense work over many years together with the European clinical trial groups. Next slide. And yeah, we can go over the agenda maybe quickly. Aims I'm delineating. We will talk about the registry status to date, and then give a lot of room for discussion with you to discuss your needs and how to go forward. Okay, we can go on. So just in a nutshell, where we are, I think the achievement is really great that we have by now 28 ESCPs developed, and the purpose is very clear. But it's good to underpin that we would like to see the standard of care treatments really picked up and used throughout Europe whenever a child cannot enter into a frontline trial. Yeah, and this we discussed this previously, has to do with complexities and more intense burden in administration and data capture in the frontline randomized trials. And we really see it as a good basis really also for collaboration and twinning, and also to show patient pathways, and in particularly to highlight and outline what are the state-of-art diagnostics and the important interventions. So this you know all very well. And when we now refer to the registry and why we have built it, we were actually motivated directly through the Commission that on the one hand, they wanted to have clear registries, so capture data on rare diseases. And we wanted here to contribute and measure an improvement of outcomes potentially once we establish common guidelines with common efforts throughout our community. And to enhance this beyond the limits that, if existent, a national cancer registry has, to understand childhood cancer typic specific risk factors, and also to understand if such a guideline can be applied and given, or if the problems with drug shortages or other obstacles that hinder actually applying the guideline. So we tried to have it slim, and there is a core module that is completely aligned with 16 data commons. So this is really brief. And GRC stands for the Joint Research Center, that are responsible within the European Commission and the delegated partner for the registry business at large in Europe. And since these data commons are non-specific and very basic, descriptive, we have then asked to the clinical trial groups that have provided the guidelines to develop modules that are disease-specific, because what we wanted to get are the guiding risk factors to understand risk groups when we capture the patient's outcome. So these data commons in the modules target up to a maximum of an additional 50 Some were hard to hold back for the reasons of complexities and sub-disease groups, but in comparison to a clinical trial, it's a minimum and about 10% what frontline trials ask, and frontline trials are even higher in the data items they ask. We worked with and intended for pseudonymized data sets, and this is an integral part of the build registry. And but nevertheless, on an institutional level, you are not under data protection as such, and whatever you capture in the registry, you could use it to inform your own national cancer registry on the number of patients that you have. And in smaller countries, or in particularly where you don't have a good national cancer registry, you could use this platform even to establish one by this means. Next slide. So this is my really friendly reminder, because I think we are all happy that you have become partners and members of our ERN network. And we have signed contracts together, and indeed in this contract we all committed to these two actions that I was just referring to. On the one hand, working constructively together on the guidelines and trying to roll them out in the best interest of patients, but also to capture the data and to put data into the registry as part of the ERN committed duties. Next. So the story always goes on for a while. Yeah, so we already have a little bit of a history to look back, starting very bravely in 2019, where I decided that this project would be worthwhile. And you very well remember the story, I would assume, from the General Assemblies that we had together. And we started 2021 with EU funding to develop the registries, and went step by step from the core module to this additional, more specific disease modules with inherent risk factors. In 2024, we submitted as a test case, and I come back to this idea, the whole registry in Austria. And we were trying really to be very smart, so because with the many ESCPs that we have, you don't want to go for any and each to the ethical committee, because this is a huge burden. So we packed everything in one application registry study protocol that covers all what is currently existing. And now we are actually here to encourage you to start to implement this, and to also inspire you to start the ethical process in your respective institutions. And I hope that we have made a package that makes it easier for you and hopefully straightforward. Next. So this is a reminder, and you all are using to various degrees these different guidelines. I mean, the slides are shared. I will not read through them, because I would assume you're very much aware of all of those. So we are up to 28, two just in the final approval. And all what we have in the yellow on the right are those ones that are currently under development. So we achieved already a real lot, and the work is ongoing wherever we see a niche, or where the work simply has taken longer than previously as expected. Next. So, and this is probably something that interests you, because we have been taking the the widening countries as the most important target group, but you all will remember the way we have written the ESCPs very clearly. All the European clinical trial groups and also parents and patients said we don't want to have second-class guidelines. They are first-class guidelines. And whenever in one of the European countries or in the European clinical trial groups, a protocol finishes off and the new one is not available, they will use the same guidelines, with confidence. I think this is very important, that this is a really common standard. And should we ever have new evidence, then I think that's for sure, we upgrade the guidelines and bring it to the next upgraded version, as you would do in a clinical trial protocol for amendments. So I think the numbers in the way they are used, I think they are self-talking. So we have really a very nice take on and buy-in. And so I'm very happy to see this. Some are quicker, some are slower, but everybody is very nicely coming along. Next one. So the registry. How is it done? How is it captured? We started the work with a specific IT provider in Italy because we had already very good experience from the partner project that you might remember. That Gianni Bisogno was charged to create with the respective very rare tumor national registries for the very rare entities, and worked with a company called Data River. And so we had already a lot of experience with them. They have all the profile that it takes. And we are covering the costs of these partner registries under the wing of ENPET-CAN. So this registry that we are talking here is like the CPMS 2.0, free of charge. So this, I think, is an important one to take along. And the major takeaways are, and the most important thing is, if you start registering, please put in the 16 core variables. So this is almost this data that a national cancer registry would take anyway. And to better understand the patient data, then these additional variables is really just about risk groups, potential outcomes, and some questions, very limited, that we ask if you have been able to give the ESCP, or if there were shortcomings so drug shortages or any other obstacles in the therapeutic or diagnostic pathway that hindered actually the application. That's all what we want to understand. No details on drug doses, etc. Just a high-level view to understand how applicable these common standards are really. So let's go to the next slide then. So just in another way to show it, in the middle, this completely harmonized 16 core data set, and around these different modules that were developed and are dedicated to respective risk factors. Next. So how many modules are available by now? A total of 14 can be completely documented. And in the background, we continue the work to complete also for all the other entities that are already in terms of ESCPs established and still need this add-on module. But the core data of any ESCP you already can register as of now. Next. So what is actually behind this registry on the longer term, and what does it mean? I think, and I will talk about this a little bit later, or we will discuss together, we are covering in Europe or addressing approximately 340 clinical trial not units, but hospitals that are engaging from geographical Europe, and all institutions that treat childhood cancer cases are able to participate. But under the rulings, and this we will be discussing, of using a registry, the burden to go through ethics cannot be taken away. The registry never should compete with any randomized trials. So if you are participating in the one or in the other indication in a clinical trial, don't worry, those patients, you don't need any double registration. We are only interested here in the cases that are simply treated according to an ESCP guideline. And if you calculate it, this registry one day will be very informative and powerful. And we were conservative because it will grow over the year easily to capturing patients in the range of 4,000 to 8,000. It's hard to predict because it has really to do on the process of being able to use the registry. Next one. So coming to practicalities, this is always good. This just gives you the front page of what I call the study protocol. And that refers that this is a registry that you, when you bring it to ethics, for European standard clinical practice recommendations in the field of pediatric hemato-oncology. Those available you will find inside this. When we have add-ons and more, then, oh, the slides are not moving forward.
I'll briefly stop sharing and share again.
Okay, thank you for notifying us.
Okay.
So is
everybody can see the.
Okay.
Can you see the practicality slide now? Is it? Yes.
Yeah. Positive feedback. Okay, then we are aligned again. So what else will you need for ethics? Obviously, an informed consent. So we have created a brief and age-adopted informed consent for this registry, brief and to the point. It's also important to understand that, this is an important message, that we will have pseudonymized data only inside the registry and no personal data by definition. And there is within the registry an integrated tool based on UPID. And I think this decision was very wise because we easily can get this pseudonymization process inside of the registry, because the SPIDER is another promoted tool, is creating a lot of difficulties, because in the current times it creates a lot of hurdles on the institutional levels. So we had just a webinar on registries, and I felt quite happy that we have decided for the time being to really use a tool that is ready to use and less burdensome, and should not create for you major hurdles when you run into the active phase. Next slide. There we go. So these are the tasks that I would see upcoming, and this is also of the selling point. So for all the ESCPs and to be able to register, you should only. Now there are no slides seen. Martin, what do we have today with the internet connection?
I have no idea.
Feedback.
I don't know.
It's our last slide anyway, so it should work. Can you see them again, Nuno? Yeah. Are we okay? Okay, fine. So going to ethics only once. Yeah, that's you apply for the registry as a whole and not for the single disease entities. It worked very well in Austria as such with this study protocol that I have mentioned previously. The documents for ethical submission, protocol, and informed consent, we provide you in English language. You will probably need your local language, obviously, for the informed consent. And I'm currently increasingly, in spite of age, getting adapted to ChatGPT functions. We can give you a link for this because at least it's very helpful if you upload the English version and you ask for the translation in your own language. It will give you a translation that where you already have 80–90% of very good wording, and with you being a native speaker and also respecting what maybe your ethical committee requires in specific phrases, this is the adoption that we cannot take away from you. Yeah, but it should be quite easy and straightforward to transform these informed consents then with the help of modern AI quite quickly into the local appropriate language. And we will give you the link and also can give you guidance on how to do this. Are there some hurdles to be expected? The ones that you should prepared for and what we have seen previously, and where although we are trying to gain oversight, have not yet complete oversight, because legislations are sometimes subject to different national rulings. And at that point, it can be that your ethical committee is completely comfortable with the notion of a registry, but you might come across to some ethical committees that would call it an observational or non-interventional study. And this is completely different from a trial where we are for investigating drugs and treatment improvements. So the notion is the non-interventional, and here's a variation in national interpretation. Either works, it does not matter, but here, in case you need help, I'm happy to support and guide you if there are tricky questions. We can discuss this then, because this is my last slide, in a minute, how this works for you. Sometimes data protection questions pop up, and we have seen hurdles depending on the respective institution, that sometimes data protection officers might be overprotective. But I think the most important is to say that you don't have personal disclosing data in the registry. It's pseudonymized, and this should be fine. Yeah, if you get questions after a DPA, which is a data impact assessment, or a data sharing agreement, if you get such tricky questions, I don't want to impose these procedures on you now. Our ethical committee did not request it, but I know from other year ends that some institutions have very engaged people, and such questions might pop up. If so, come back to us and I will be trying to help. And I think it's also important that in this registry, which is helpful, we are not aiming for capturing image data. We are not capturing whole genomic profile signatures. We are just going, if at all, for very limited biological established risk factors, yeah, that are per se as such not sensitive. Yeah, so these are these usual talks one may encounter. Once you are cleared from your ethical committee, you should notify us, and we will do this in groups or for you alone. to have an activation training by Data River, who built the registry, so that you get a first hands-on guide how to use it, to see the items, rather than you search on your own the first time. So it's really more fun to have this intro, which will brief and short. I think it should also give you an intro how you activate the pseudonymization code. But once this is done, you are cleared and should be able to fly and enter these patients. Next one. Yeah. So we have a couple of questions to you, and Martin will capture the answers. Once we are through, it's very brief, 5 questions that we are very interested, and then we have easily 25 minutes for open discussion and all the further questions that you still might have. So if I can invite you to please give your answers, and I hand over to Martin.
Yeah, okay, so I will stop sharing the screen now, and we'll start the polls questions. So I will start them one after each other. Just give me a second. And
Poczekaj,
if
bo ja
you're
to
using...
niestety muszę z tego odpowiedzieć.
Sorry, Anna.
I think somebody's unmuted, that's all.
Yeah.
Yes.
I will start the questions one after each other. So if you are connected via the Teams app, you will see a pop-up. If you're connected through the browser, you can find the question in the chat coming up, and you can answer. The first one was, do you need ethical approval to activate a registry in your country? And you should see the question now either popping up on your screen or in the chat. And please answer. I will not close the voting. I will keep the questions open now. You can continue answering if you have not done so already, but just that you know, I will one after each other launch the questions. The second question was, do you already have a rule to allow one national vote for the registry for the whole country, or does each single institution need to apply?
Hi, Martin. It seems that the
Hey,
voting
Karen.
does not work for me. I'm sorry.
Do
Can
you-
you see my response, or you cannot see it? I tried, but it shows me there is some impossible to vote from my computer. Do you see my responses or not?
Are you? Yes, but I just a second. Are you connected with via the browser?
Yeah, with via the browser. No, via the
Yeah.
app. With the
Yep.
app. Yeah.
Hold on a second. So yes, I can see that 8 people responded. There are 2 people where it says anonymous. I guess one of them might be you, but the response is captured.
Okay.
Okay.
So if we conduct our team of 3, ideally, I think you should have 13 responses, people being in here. So maybe we have to wait a little bit longer by each.
Yeah, as I said, I will keep the polls open. You can still answer add your answers until the end of the webinar.
Okay,
Or put it in the chat. That's also
the
good.
chat. Okay, because otherwise, okay, good.
The next one is a question where you can answer by writing, in writing. So have you had previous experience with terminology with your ethics committee registry versus observational study trial? And you could still answer the whole time. I will just launch the next question. What is your estimate for the time effort to implement the registry? And then lastly, just to launch it, more specifically, time to expect for the ethics approval. Okay, now all the questions that we have, these 5 questions, they're all open. You can answer, as I said, the whole time until the end of the webinar. And maybe if you have questions on your own, I think Ruth and people can ask now.
Okay, so we will look into the background. Maybe if I can stress you, Martin, is anybody part of this meeting who does not need an ethical approval?
Yes, I'm opening the results. So we have, for the first question, we have 9 responses. 67% do need an ethics approval, 22%. Maybe I just opened the detailed responses. It's easier. 2 people said they do not need ethics approval for a registry. The others said yes. For one, it was an unsure.
Okay, so this is subject to clarification. And I promised that this is your time now. So I stop teaching and preaching and really want to open the floor for any questions on the processes. Should there be none, then I can talk a little bit about political insights into registries overall and ambitions, but this would then be rather a time fill. And I really would like to hear from each of you how you potentially foresee in which time range this could be implemented and what questions you have. And you don't have to cancel your holidays, because somebody answered that in holiday time it may be longer.
It's me, sorry, but I think that we have holiday time now, almost 3 months, and almost everything is closed.
Well, we respect holiday times. I think we just want to encourage us all together, and whenever you are operative or you can launch it, that's fine with us. But we really want to energize you to put this really on your agenda whenever the time is ready for that. So do you see any problems apart from holidays?
Karen has his hand raised.
Hello, I would like to ask just a general question. If I understand the registry correctly, it's when someone is not enrolled in the other registry or within the clinical trial, is it mandatory for us to enter the patient to the ESCP registry, or is it just recommended? This is the question that I still don't understand clearly. Is it mandatory or not to include the patient to the ESCP registry?
You know, we cannot control this, but we see the patient numbers in each of the partners, so members that we do have in the ERN. And so we understand that we will not see in this registry the patients that are in a frontline randomized trial, because you might participate in the one or in the other. But where you use an ESCP as a guideline, please do so. Yeah. Because
Okay.
we need to create a visibility. Yeah. If you're doing something completely different, what I don't hope, but sometimes some colleagues refer to a US protocol and use this one that is then, so to say, not required, right?
Okay. And another, I think, I just need a clean answer, but I think it's obvious. But I have to ask, will ERN provide any financial support to our data managers or to establish a data manager to put the data into the ESCP registry?
As we have set up the concept of advice, currently there is no budget for it. Yeah, so it's expected as part of the contract that the healthcare provider has signed off of being a member to have these resources to work with the CPMS and to work with and to put data on a registry. So that's part of the contract that the institution has signed when becoming a member.
Okay, I understand. Thank you.
So, any more questions? Can
I ask something? Besides the effort to implement the registry, do you have an estimation how, in a daily basis, how much work or how much time from a professional do we need to register a patient?
I would hope and think that it's very little time, because the core variable data set probably to type this data into the computer might take you 10 minutes, if at all, if you have the chart in front of you, and you're not obliged to fill all the questions. I mean, if you have a new patient intended to treat on the registry, if you put in the 16 variables first, and then you have all the time of the world. Once you have received from diagnostic the risk factors, which you are doing anyhow, yeah, this you will put in, and the questions are very limited. Yeah, so when we are going through the training, yeah, we will walk you a little bit through that you have a better feeling what is in there, and the rest basically is then outcome data as well. There's a question, then you follow up alive or dead or relapse. That's it. And then there's this one or rather small section. Have you been able to deliver the ESCP? And then you answer yes or no. And if you say no, then there's a reason, yeah, because change of strategy for relapse or drug shortages, or I could not fulfill the diagnostic criteria, etc. But that's it, yeah. So I think in the hands of a professional, it really should be a few clicks in a reasonable time. Yeah, and that was one of our ambitions, to keep it really slim.
Okay, thank you.
Okay, who else is around that we have not yet seen or heard? Nuno, how is it for you? Nuno is probably speaking to somebody. The only one I see. Any more questions? No. Let's just see who else we have. Anna Maria.
Hello. We will need to submit to our local ethics committee. So we need the papers to make the submission. And as a reference center, both hospitals of the center must submit to each ethical committee.
Okay.
That's it.
Yeah, which is normal or the normal requirements across Europe. Yeah,
Yeah.
that's sadly so. And so we will, the documents to submit, we will provide you with, yeah, and then for the rest, what form your ethics require, obviously this is in your hands, it's your usual procedure.
And also a data sharing agreement. Yes, we need both things.
Okay, then you would need to tell me what, maybe you have a template, what your institution requires. I'll check, then we can sign it off. Yeah, but it's easier if this comes from your side to me.
Okay.
We will respond back and help you to get that formally approved.
Okay.
Yeah.
Okay.
Sorry, Ruth, I was unmuted. I work in the same hospital as Success, but Portugal has always the same problem. We don't have data management in all hospitals. That's a work for doctors, so might be complicated if, as Anna asked, if the workload is too much. That might be a problem. Which problem? We don't have data. There are very few data managers in Portugal in hospitals. That's something we are trying to work with Ministry of Health, but it's a huge problem. If the workload is big, that will be a problem.
It shouldn't be, yeah, because I think if you're writing a medical report, it just should take you a few minutes and not much to enter the basic outline. And we will stay in touch with your experience, obviously, but I will not overburden you with any questionnaires because sometimes it's better to talk directly and to solve issues. But I think it's already worthwhile to put in the basics so that we understand basically this is a patient with ILL, low risk or high risk, has received the ESCP, I could deliver it. No problems, the patient is alive. So basically, that should be the story. And the risk factors depend on the disease. Yeah, it's only the established ones. Yeah, for a neuroblastoma, we will ask: is the patient MIG-N amplified? Yes, no, because that makes a huge difference in treatment pathways. But this is, I think, really very straightforward. Okay, can I help otherwise?
I think Jelena had a question. You had your hand raised.
I don't see more.
Jelena, you had your hand raised.
I wanted to say, but I responded in the survey. There are 3 affiliated partners from Croatia, so we need institutional approvals, which at least we need 1 translation. So we will find somebody who, so it makes our life easier. The thing is that institutional ethical committees have very, very different demands. So we have seen it in other studies and in other protocols, but we can surpass it somehow. At least in my institution, in Children's Hospital Zagreb, things are going easy. So thank you for this initiative.
Okay. So we fully understand the burden of institutional approval. It's currently high on my agenda. I'm, as 1st of July, the chair for all the EINs in the so-called trio, so 3 people trying to guide and tackle tasks that are common for all of us. And we have opened, let's say, the topic together with the GRC. Because on the one hand, but this is the long-term future, everybody talks about the European health data space, and there will be registries foreseen, yeah, with automatic access. Dream of the future, will take time, where no ethical approval or informed consent is needed at all. Yeah, so this is the other extreme. But what in the interim I would like to achieve, that, like as the example goes in the clinical trial regulation, where we have now one ethical vote for one trial that applies for all of the country, it doesn't make any sense, yeah, that we have this burden for the registries. And I'm currently trying to find out with the Commission national contact points and to understand through the board of member states better how every country is positioned and who can change. It might be, I'm not sure if this is possible top down like it was for the clinical trial regulation, but if we find any means to do so, we will strive for it, because there are a lot of good arguments to lower the burden. Yeah, and the winning ones is you want oversight on in registries on rare disease patients, no matter what's the indication. You need to lower the burden in the processes. Yeah, the most crazy one is that you have to go for an institutional approval. Yeah, but currently I cannot take that away because this is country rulings. We just can try to work together, make this very clear so that hopefully there is a way for common sense, and we can lower it at least to one national vote per country. And that obviously then facilitates also the registration or the patient data capture when this goes away. But currently we have to deal with what it is. Yeah, some countries function already a little bit different. So at least I was informed that France has for registries this national approval already in place, but this is currently rather the exception than the rule. Yeah, but we'll see. Okay, are there any more questions? So please, I only can say we will send you the documents. Please tell us if you need help, then we will try to support you, and we will come back in reasonable time to find out. So after the holidays, if you have started, if there are problems, if we can help. Yeah, and otherwise, please come back anytime. So if there are no more questions, I don't steal more of your valuable time. And let you go back for whatever you have to do. So I wish you a good end of the day, and hopefully we can work this out together successfully and in the not too distant future. So thank you very much for joining today.
Bye.
Thank you.
Thank you very
Have
much.
a nice
Bye.
day. Bye.
Thank you.
Bye.
Thank you. Bye bye.
Bye.